patients with this. So again, my name is Dr. Diana Feldstein, and I am a physician volunteer with the MAVEN Project. Thank you all for coming today. And our talk today is sponsored by the Anchor Clinic, which I had on a different piece of paper because I'm very prepared, is with the Urban Health Plan. And our talk today is going to be Menopause, a Primary Care Approach. I'd like to talk a little bit about Dr. Horwitch. She is an MD, MPH, in the outpatient primary care physician in practice for over 30 years. For 20 years, she worked with the Virginia Mason Medical Center Internal Medicine Residency Program as an associate program director and as a key clinical faculty member. She is a clinical associate professor of medicine at the University of Washington in Seattle. Dr. Horwitch was the governor of the Washington chapter of the American College of Physicians from 2010 to 2014 and served on the American College of Physicians Board of Regents from 2014 to 2018. She's currently a member of the Board of Trustees for the Washington State Medical Association. Dr. Betsy Strong was a general internist and primary care physician for PAMF, which is Palo Alto Medical Foundation in Sunnyvale, California, for 26 years. She dealt with acute and chronic medical illnesses, as well as women's health and geriatrics. And with that, I'm going to start sharing my screen and turning it over to you guys.
Great. Thank you so much, Diana. As soon as we get the slides, we can actually move to the fourth slide because you've already presented all the other information, the title of our talk, and about the CME. So Dr. Strong and I, or Betsy and Carrie, will be sharing this talk. So we'll be going a little bit back and forth. What we would like you to do is to please hold or put into the chat or the Q&A your questions. We will have time at the end when we will take all the questions. So we won't do questions in between, but at the end, that will probably be a little bit easier. Can we go to the fourth slide that says acknowledgements? One more. There we go. You've already heard about both of us. We are both retired or mostly retired internal medicine. A couple caveats, neither of us are gynecologists or endocrinologists. The topic we're going to talk about today, we are not discussing gender-affirming hormones or trans male use of hormones for menopausal symptoms. And we did borrow some slides from several talks that were given at the American College of Physicians, several of the national meetings from Drs. Kling, Merriam, and McNeil. So want to give that acknowledgement. Next slide, please. Our objectives today, we're going to talk about what is the diagnosis of perimenopause and menopause, some of the common symptoms that you might see for both of these conditions. We will talk about some of the benefits as well as some of the risks for hormone replacement or menopausal hormone therapy, both systemic and topical or vaginally. And also we will talk a little bit about some of the non-hormonal options that are there for those who prefer not to take hormones. Next slide, please. So when we talk about a definition of menopause, basically the true definition is when a woman, not from surgery, but has not had a menstrual period in 12 months. There is also surgical menopause that can happen, for example, if a woman has to have the uterus and the ovaries removed, either for cancer or for other diagnoses. So that is the definition of menopause. No menses for 12 months. Perimenopause is the time that leads up to menopause. This can actually be a time where there may be irregular menses. Patients may go several weeks or months without a period and then get one. However, if bleeding is very heavy, if it is unusual, if women are having clots, even during this time period, it needs to be worked up. Vasomotor changes, which are some of the most bothersome changes during this time frame for women, can occur anytime and can last for a short amount of time, can last for several years. It really is variable and very independent. And again, can last somewhere between 4 and 7 years, but I even had patients who had it for years and years. The average age of menopause is around 51, but typically somewhere in the later 40s to later 50s. Premature menopause, which used to be called premature ovarian failure, which we don't say anymore, is if a woman goes into menopause before the age of 40, and that may and should have some additional workup. Next slide, and then Betsy is taking over.
Great. Thank you, Carrie. So this is the one of the excerpts from American College of Physicians, and you can see the green and yellow logo. Dr. Merriam talked about the different stages during the transition. And in the early menopausal transition, there's variable menstrual cycle length, so typically skipping of periods. And then in the later transition, there's amenorrhea, vasomotor symptoms again. And what do we mean by vasomotor symptoms? It's hot flashes, night sweats. And with the early postmenopause, these become more severe, and it becomes more prominent. In 5 years after the last period would be considered the late postmenopause, and that can go on for a decade, if not longer, and there are increasing symptoms of vaginal atrophy, and those tend to get worse, although the vasomotor symptoms may start getting better. Next slide. So other aging changes would be thinning of the hair, vaginal dryness, which is part of the vaginal genital urinary symptoms, skin thinning and dryness, joint and muscle aching, and weight change. We are going to be talking a bit about anxiety and depression. And I should just mention here that in menopause, about 30% will experience anxiety and depression. And if there's a pre-existing diagnosis, about 60% will experience anxiety and depression. We may be missing one slide prior to this. So Diana, if you could go back, I'm thinking that we're missing one, but go forward now. Thank you. Could be. Huh. Okay, there are a few slides that are missing. Okay.
Dr. Strong, would you like to see the outline and just let me know where you want me to start?
No, this is fine.
Oh.
There's one slide that had to do with, it was also a green and yellow slide, and it basically discussed, I can just say it off the top of my head. It basically described the symptoms of menopause, vasomotor we talked about, and then the genital urinary syndrome, also called GSM, genital urinary syndrome of menopause, is vaginal dryness, dyspareunia, that's pain with intercourse, urinary incontinence. Those are all part of GSM. Sexual dysfunction is another example, but that's typically due to related to GSM, genital urinary symptoms. And then anxiety, depression, mood disorder, that's also all part of the picture. And I apologize that that slide is missing. We may have another version of our slides floating in the air somewhere. So our lab tests needed to diagnose menopause. Menopause and perimenopause are clinical diagnoses. So lab tests such as hormonal levels are not necessary for diagnosis except for premature menopause, as Carrie had mentioned, menopause before age 40. Pregnancy should be ruled out for irregular or absent menses. And then a thyroid test is reasonable, as vasomotor symptoms could be a thyroid issue. Next slide. And from American College of Physicians, goes over the same thing. Lab evaluation is not necessary if in individuals over 45 with typical symptoms. Think about lab evaluation if there are underlying unusual or atypical menstrual disorders, current use of birth control, hysterectomy or history of endometrial ablation, and absence of the typical symptoms. Next slide. You would expect to see with menopause an elevated FSH or follicle stimulating hormone. You would expect to see a low estradiol level. As you recall, FSH is from the pituitary and the estradiol is from the ovary, but this can vary widely during the perimenopause, so not very reliable. A prolactin level would be considered for amenorrhea, and you would think about that even if there's no nipple discharge. And then an endometrial biopsy is important for anyone who over age 45 with abnormal bleeding or atypical bleeding, or under age 45 if there are additional risk factors such as polycystic ovary syndrome or obesity that might increase the risk of endometrial hyperplasia. Next slide.
Okay, so the question always comes up is, does menopause need to be treated? And I have always been a believer that menopause is not a disease. So I think it's important to remember when we talk about the treatment options for symptom, menopause is not a disease. It is a normal aging process and phenomena. But the symptoms that Betsy was talking about, especially those vasomotor symptoms, can be quite distressing and really bothersome for women. And there is data to show that treating these women at a certain time in that menopausal sort of history may be beneficial, may reduce not only symptoms, but may have some other positive outcomes. And we'll talk a little bit about the risk later. So again, for a lot of women, not all, but a lot of women, some of the benefits may actually outweigh the risks. And really what we're talking about, and we will keep mentioning this over and over again, is shared decision-making is really important here for the treatment. Hormones are not the only possible treatment. And so I think it's really important that you discuss all of the potential benefits, risks, and what the patient actually wants to do for this time in their life. Next slide, please. So what does the data show about some of these sort of treating the symptoms or not? Well, there are some studies, and this comes from an article about 10 years ago in Menopause, that women who were not treated for their particularly vasomotor symptoms, that is the most common reason to be given hormones, that there actually was higher healthcare utilization. So there were more outpatient visits. A lot of those visits that you can see were due to the vasomotor symptoms. There also may be some slightly higher cost for women with these symptoms. Again, that may be doing more lab tests or not realizing what it is. There was also a lot of missed work and indirect work productivity loss because a lot of these women really felt terrible. They couldn't think, and dysfunction. In a study of over 4,000 women in primary care, again, 13% of women had at least one adverse work outcome because of menopause, and 10% reported missing work in the past year. And that's estimated to cost over 1.8 billion. So I realize that we don't necessarily treat because of economics, but it really is because of the distress, perhaps for women who are having pretty significant symptoms that may benefit most from treatment. Next slide, please. So let's start with a case, as always. So a 39-year-old comes to clinic. She's having hot flashes. She has not had menses for 4 months. She did a home pregnancy test, which was negative. She has not had any uterine or ovarian surgeries. She did have a prior pregnancy with 1 child, but no other pregnancies since then. She is really, really bothered by the symptoms and has heard about various issues with hormones, doesn't know what to do. And interestingly, her mother kind of had some similar issues at a young age and also stopped her menses at age 42. So what should you do? Next slide. So this may be a case of premature ovarian insufficiency, or otherwise called premature menopause. Again, remember, it's menopause before age 40. Now, she's only had 4 months, so officially not menopause, but this could be natural. Again, it could be surgical. There could be a hormonal issue. And again, most of the studies do show that if there are no contraindications to hormone therapy, because these women are so early, that they actually will have more benefit from going on appropriate menopausal hormone treatment. Because if untreated, they actually have somewhat higher risk of coronary heart disease, osteoporosis, genitourinary symptoms, memory issues, and actually overall mortality. And you have the reference there. So the recommendation is actually to treat women with both estrogen and, if they do have a uterus, obviously progesterone. And the dosing you actually need for premature menopause is closer to the dosing you would give for contraception. So not the typical dosing, which is very low dose for normal menopausal hormone therapy, but actually a higher dose that's more consistent with what you would normally have for that age group. Next slide. Case 2, we've got Jo, who's now a 49-year-old woman. She comes, and again, if you have questions about any of these, please write them into the chat or the Q&A, and we will get to those later. Thank you. So our second case is Jo. She's 49. She's coming in because she's, oh my God, she's sweating, up all night, hot flashes. Again, her last menses was 4 months ago. And they've been, you know, maybe a little irregular for a couple of years. Again, she did a home pregnancy test, which was negative. She's having trouble sleeping, and the hot flashes are really, really bothersome. She's getting at least 3 to 4 a night and several more during the day. And she had a grandmother who had breast cancer at the age of 80. She herself has no history of venous thromboembolism, stroke, or coronary heart disease. So number 1, is she in menopause? Yes or no? Number 2, does she need any labs? Number 3, does she need treatment? And number 4, what might you recommend? So let's go to the next slide. So let's talk about, wait, these slides are, okay, little messed up. No, keep back one. Okay. Yeah, oh, sorry. Okay, thank you. Yeah, we missed a couple. Okay, so by definition, remember, menopause is 12 months with no period. So by definition, she is probably perimenopause. We do need a pregnancy test, even though she did one at home. So again, common cause of people thinking they're in menopause could actually be they're pregnant, especially if they were not using any contraception. Maybe get a TSH, because again, a lot of vasomotor symptoms, you would probably want to make sure that that is not a contributing factor. And then again, you start the shared decision-making discussion about she might benefit. She's really significantly impaired by the vasomotor, and she might benefit from being on menopausal hormone at that stage. So again, everybody's different in terms of their wants, their diswants. You might want to ask about the genitourinary symptoms, because if she's concerned about systemic hormones, maybe she would consider vaginal if that's an issue. Again, talking about some of the non-hormonal pharmacologic treatments, as well as the quote unquote non-pharma treatments. And then again, going over what are the benefits, harms, and contraindications for hormones. Next slide. One more slide. Okay, so back one. So it is important to know what some of the absolute contraindications are to hormone therapy. And by hormone therapy, we are specifically talking about estrogen, okay? Maybe progesterone. So if a woman has a personal history of breast cancer, that is a contraindication. I would not recommend starting hormone therapy if there is unexplained vaginal bleeding until you get that worked up. If someone has a history of endometrial cancer, that's a relative to a concerning contraindication. If a woman has had a stroke, MI, or has known coronary heart disease, again, contraindication. Any history in the patient of any venous thromboembolism, or sometimes those with an inherited high risk. So, you know, that may be a protein C deficiency, protein S, And there are several others which could put somebody at much higher risk. If somebody is having active liver disease, serious gallbladder disease, obviously if they are pregnant, and the only reason for the prolonged immobilization would be because of the increased risk of clotting. Now, again, these are not contraindications to hormone therapy, but a concern and a discussion needs to take place. So for women who have higher risk for breast cancer, and again, there are several tools that you can use. There's the Breast Cancer Surveillance Consortium or the GALE model, and there are various guidelines for what would say, lower risk, no, not a problem, or higher risk, still have the conversation and still have the conversation whether it's worth it to the patient for that risk. Again, you can use a risk calculator for coronary heart disease as well. Significant hypertriglyceridemia. And so that's usually when it's well over 500 or more. Current smoking, again, not an absolute contraindication, but just like we say with birth control, smokers and estrogen could have a higher risk of adverse effects. So we would clearly recommend smoking cessation. Again, you could still consider hormone therapy, but really monitor them carefully. Next slide.
May I add something, Carrie?
Absolutely.
To the last slide. If we have time at the end, I have a couple of slides to show the breast cancer calculator and the other calculator you're familiar with, which is the ASCVD calculator. And I also want to mention that regarding migraines, this comes up quite a bit. Migraines with aura. You have the typical photophobia, zigzag lines, and so forth. Many of the references, including ACP, said that it was appropriate, it would be okay to treat the menopausal women with migraines who are also suffering from severe vasomotor symptoms, whereas those with severe migraines who have stroke-like symptoms, hemiplegia, and numbness in one side of the body, those would be clearly not the appropriate patient for systemic hormone therapy. So just wanted to clarify that a little bit.
Yeah, thank you. Okay, so our case continues. So she's concerned about, so you talk about all of this, she's concerned about side effects of hormones, and she's heard about bioidentical hormones, herbals. She wants to know if she should do any of those and what other options might there be besides hormones. Next slide, please. So some of the alternatives to hormones. So there is this thing, quote unquote, bioidentical hormones. And there is really no data regarding their benefit, their safety, and they're really not bioidentical either. So it's a little bit of a misnomer. And there are none of the guidelines that recommend using these compared to, just using a low dose of hormones. They're still hormones. So they still carry the risk, but we don't have a lot of data. And I know Betsy will want to add something, so I want to just get through and then she can add some additional information about bioidentical. Same thing goes for a lot of these quote unquote herbal remedies. And you may have heard of some of these: black cohosh, primrose oil, dong quai, red clover, and several others. Again, there is inconsistent data regarding any benefit for any of these. Also, not a lot of data, since most of the studies on these rarely looked at a lot of the harm. I have actually had patients who have taken, especially dong quai and others, where they've actually come in with severe liver toxicity due to some of these. We really don't know what's in them from a lot of these preparations. And so I don't actually think these are terribly beneficial or safe for our patients. And then in terms of soy, again, probably not really much harm, including even somebody who may have had breast cancer, and there's new data on that. But what we don't really know is, well, which type of soy is the good kind? How much soy do you need to take in that actually will have any decrease in especially the vasomotor symptoms? And then again, there's some smaller studies looking at acupuncture. And from, again, there's a systemic review, which is not a randomized controlled trial, necessarily looking at those who get it, although some of them had acupuncture with sham acupuncture, and there was some benefit for some women at reducing some of the vasomotor, and there was maybe some improved quality of life. And really the harm with acupuncture is really, really minimal. So if we have to talk about kind of all non-pharmacologic treatments, I would probably maybe start with acupuncture and see if that has any benefit for those women who don't want to be on hormone therapy or some of the newer meds, which we'll talk about in a minute. But I know Betsy wanted to say something else about bioidenticals.
Some of the experts talked about the bioidentical hormones being a problem because not only is it not approved by the FDA, but they're basically the practitioners are mixing a whole slew of hormones, as Carrie mentioned, estradiol, progesterone, DHEA, testosterone, and basically using preps like oral, sublingual, vaginal, topical patches, and they use different types of tests to monitor levels, including salivary and urine. None of this is standardized. So there's no way of knowing the purity of the compound, what exactly the dose is, and there's no labeling as to the risks. If you look at for instance, vaginal estrogen, it has a label on there about the possible risk. It's a little bit too strong even, but there's no labeling here, and patients have really no idea what they're getting into. So it's really what they call the wild, wild west and yet it's a very profitable and a booming industry.
Yeah.
And patient education is super important here.
Thank you.
I also wanted to say, sorry, apologize. The other types of therapy might be cognitive behavioral or relaxation therapy, especially for those women who are suffering from anxiety and depression. And I understand that the vasomotor symptoms can be so severe that it's kind of like a panic attack. I've never experienced it myself, but I know that a lot of women are really miserable. So that type of therapy would be useful. Thank you.
Yeah, and just some other things, even though it's not on this slide. I mean, having gone through menopause and the vasomotor, there are other things that women can do. Number one, dressing in layers, because you tend to get hot then cold, then hot then cold. Same thing about sleeping. So typically keeping the room a little cooler, so you can kind of put covers on and off, are really helpful. Sometimes just even keeping like a little cool washcloth during the day if you need it can also be very helpful. So those are just some very simple things, again, for women who really don't want to take medication. Next slide.
Yeah, and they also mentioned weight loss as another option for those who are at risk. Carrie, should I do this one?
I think Dr.
Okay.
Horwitch, you might be muted.
No, I am. I had to cough. Go ahead.
Oh.
I can do this one. Okay. So what about other medications? SSRIs like citalopram, SNRIs like venlafaxine. Data shows that these can reduce vasomotor symptoms and maybe a good alternative as well if patient has mood issues. So oftentimes these will be combined with MHT, which is again stands for menopausal hormone therapy. That's the new term, whereas we used to say HRT, hormone replacement therapy. Gabapentin may work, but the side effects are drowsiness, dizziness, as you may be aware, and you want to start low at 100 milligrams at night and slowly titrate up as tolerated or if it's beneficial. There's a newer class of medication. These are called neurokinin B blockers that affects there's receptors for thermal regulation or heat regulation in the hypothalamus. And I can't pronounce this well, but it's fezolinetant, which the generic name, brand name is Veozah. V as in Victor, EOZAH. And it was recently approved and it's been showing benefit. It's contraindicated in the setting of liver or CKD. LFTs, liver enzymes, need to be followed for 3, 6, 9 months or longer. medication discontinued if they're elevated. It's expensive, about $500 a month, and not currently covered by insurance. Interestingly, I read that the drug was advertised on the screen at the 2024 Super Bowl. And there's an article from JAMA this week regarding a new drug, which in the same class called Elina, ELINEZO, Linatent. So it targets two neurokinin B receptors, and so far, after phase 3 studies, it does not show any effect on liver enzymes. So it may be even more promising.
It's not approved yet, but
No, it's not approved yet. It's just the results of a randomized control trial, right? Next slide. So case 2, and I just want to mention here that I had given this talk to the APCs at my former clinic, Palo Alto Medical, but that Carrie was willing to help me with this talk, and she added these cases, which made our talk much more interesting. I hope you agree. So our patient initially decided against hormones. She is now 51, has not had any menses for 13 months. Her hot flashes, night sweats have increased now 6 to 10 times a day, and there are no new medical issues. She's now considering hormone therapy. She's having vaginal discomfort, decreased sleep, irritability. And so what are her options, and would she benefit from hormone therapy? Next slide. So indications for hormone therapy, this would be postmenopausal women, according to the North American Menopause Society guidance that came out in 2022, and I'll get to that soon. The optimal age for treating would be postmenopausal women aged less than 60 and less than 10 years from the start of menopause. This would be the optimal age to start treatment. These women should not have contraindications to therapy. They should have moderate to severe vasomotor symptoms, significant genital urinary symptoms, and sleep and mood issues. One of the criteria also mentioned by the FDA, which we left out here, was prevention of bone loss, and not treatment of bone loss, which we used to do in the old days, but just prevention of bone loss in the setting of moderate to severe vasomotor symptoms. Remember that if here I can mention it here that if there's just genital urinary symptoms or GSM with no or mild vasomotor symptoms, you can use vaginal estrogen alone. And vaginal estrogen can be used for a longer term. It can be started at an older age. If systemic therapy is contraindicated, vaginal estrogen can be considered. So there's a little more flexibility. Next slide. So part of the reason I wanted to do this particular topic was that there's quite a bit of history. I started practice in 1992 in having worked in the past in San Diego and then more recently in Northern California. And from 92 to 2002 in primary care, we were prescribing hormone therapy, and we were encouraging our women to use it for prevention and treatment of osteoporosis, to prevent heart disease, to prevent stroke, and also for menopausal vasomotor symptoms. So in 1997, there was a huge study that was started by, they call the Women's Health Initiative, and 161,000 women were initially enrolled, and about 68,000 women were randomized. These were menopausal women aged 50 to 79, and this is a randomized controlled trial. So basically, some were put on estrogen plus progesterone, some were put on estrogen alone if they had a hysterectomy, and then the others they were matched with placebo. And the study was terminated early after 5 to 7 years due to a finding of increased breast cancer, heart disease, stroke, and venal DVT or VTE, venous thromboembolism. And since 2002, there was a dramatic decline in prescriptions of hormone therapy, and there hasn't really been clear guidance since. So with follow-up, a longer follow-up, and in subsequent years, which I'm going to go over in the next 2 slides, subgroup analysis of the data showed that this is the important thing for you to recognize. There were significant differences in risk between the younger age groups, 50 to 59, compared with the older age group, 60 to 69, and those over 70 who were treated with hormone therapy compared with placebo, as well as a difference in risk between those given combination estrogen plus progesterone versus estrogen alone. So that basically led to new guidance from the North American Menopause Society that came out in 2017 and more recently in 2022. And you'll see a lot of organizations like American College of Physicians, Endocrine Society, and they basically all quote this particular World WHI and the Menopause Society. Data from Carrie had also pulled out data from the SWAN study and the Nurses Health Initiative, which also supports the use of hormone therapy. Next slide. So again, the green and gold is from slides that we pulled from the American College of Physicians. This is from 2023, and then it quotes Manson, who basically wrote the original WHI article, and there's a review from her this May in JAMA, and I was able to hear her talk, and it was quite impressive. So basically, it's a little busy slide, but I hope that I can explain a few of the terms on here and think back of your statistics, your biostats. Here we're looking at the risks and benefits of women who are treated with the combination hormone therapy versus, that's estrogen plus progesterone versus placebo. And the other category on the right is estrogen alone versus placebo. And then they're looking at endpoints, which is coronary heart disease, stroke, venous thromboembolism or DVT, VTE, breast cancer, and overall mortality from any cause. And the difference, they're looking at the difference per 10,000 patient years. That refers to, I had to review this, 10,000 patient years would be, for example, 1,000 patients followed over 10 years. And they're looking at the HR, which is the hazard ratio. That is like a relative risk. So if you have like, let's say here's under DVT, there's a hazard ratio of 3. That means that the patients had a relative risk of 3 in terms of getting a blood clot compared to those who are not treated with the combination therapy. So that's what some terms that you may want to keep in your mind. The CI stands for confidence interval, and it just basically the 95% CI tells you how confident you can be in these results. And the narrower the range, the confidence interval, the better. So that's just the very brief biostats. And I'd like to go to the next slide, which, oops, there it is. It's the table. Perfect, thank you. It's similar data. It's just now we're talking about 1,000 women over 5 years. So it's like 5,000 patient years. And it's the number of events that occurred compared to placebo. And it's in the younger age 50 to 59 group. And the estrogen here is an oral conjugated equine estrogen, CEE, which you're familiar with Premarin, 0.625 milligrams. And the progesterone is medroxyprogesterone, and you're familiar with Premarin, 2.5 milligrams. That's the standard dose. And so they looked, and I can show you later the comparison with the two older age groups, 60 to 69 and 70 plus. It's quite a difference. But in any case, you can see that there's an increase in coronary heart disease, stroke, DVT, and breast cancer. Interestingly, less breast cancer in the estrogen alone group. Versus, that's basically surprised the investigators, and they said it warrants further study. What's not mentioned here is that in both of these groups, it's not on the slide, but it was mentioned in the paper, of course, that the risk of hip fractures is less in both of these groups. And I think that I just want to make sure I included everything that I wanted to mention here. Yes, that's it. Next slide. I think I only have two more, and that's the estrogen and progesterone. So the treatment options are systemic estrogen for moderate to severe vasomotor symptoms. There are multiple options. Topical refers to the patch, oral, or the vaginal ring. And 17-beta estradiol is closer to intrinsic estradiol, and it's now sort of preferred to the oral conjugated equine estrogen, which is Premarin. Typically, you start with the lowest dose of estradiol, for instance, 0.5 milligrams if you're talking about the oral, or the patch is 0.025 milligram per day, and then titrate up, which would be the highest dose is double that dose. And the vaginal estrogen would be for, again, for genital urinary symptoms if there's absent or mild vasomotor symptoms. And I do want to mention here briefly that there's a box warning for the vaginal estrogen that basically says this may increase your risk of breast cancer, uterine cancer, heart disease, stroke, and dementia. And so the experts said to make sure to not let that scare the patients from using it, because in actuality, the estrogen has minimal systemic absorption and is considered even safe for women who had some of the contraindications that were mentioned in the earlier slide. We can go into that later if we have time. And it's also pretty sure available in generic. Carrie can correct that if I'm wrong. It comes in estradiol cream as well as Premarin cream. Next slide. Carrie, did you want to talk about these two, or should I?
Yeah, so this is just sort of looking at the data for why, a little bit about the data from conjugated equine estrogen as a higher risk for venous thromboembolism. So if you have a choice, and this would be my preference and in practice, is I would always favor an estradiol as opposed to using anything with conjugated. And the reason for, even though that usually means that you have to give two different doses, two different meds, because it's not combined like it is with some of the conjugated. But I think the risk of venous thromboembolism to me is significant, and of course would be of concern when you can actually prescribe something that has a lower risk. Next slide. And then again, if we look at this, this is again for estrogen with venous thrombo. If you look at that one in the middle that's highlighted, as Betsy was just pointing out, transdermal, which is not even vaginal, it's the patch, really that risk is actually no different than placebo. So that's what those confidence intervals mean. And the fact that it crosses one, that there's, if it's transdermal, again, a lower risk compared to oral estrogen. So again, if you have a choice and a woman says, look, I'm really worried about, clot and stuff, then you would probably want to choose a transdermal or vaginal form of your menopausal hormone compared to an oral option. Next slide.
I don't mind talking about progesterone. It's okay.
Progesterone.
Thank you. And so progesterone must be included for women who have a uterus. It reduces risk of endometrial hyperplasia that would occur with estrogen alone. And micronized progesterone, so-called, an example is Prometrium, is preferred due to lower side effects. You could do cyclic 200 milligrams daily for 12 days of the month, or 100 milligrams daily. It's typically given at bedtime due to possible sedation. I didn't know that before. And there are combo options, as Carrie mentioned, and we used to prescribe Prempro quite a bit, and that's basically Premarin plus Provera combined. And our gynecologist at PAMP said that they had women, for instance, forgetting to take the progesterone if they were on estrogen as a separate medication. So it's really important to remind them that they need to stay on to take both. Some women are intolerant of oral progesterone, even Prometrium, and there's maybe headache or bloating or weight gain. So in that setting, the gynecologist may consider Mirena or low-dose Skyla, which is progesterone-containing IUD, but there are no randomized controlled trials on this. And here, I didn't mention earlier, most of you probably already know that RCT stands for a randomized controlled trial, which is different from an observational study. An observational study just shows often an association. It doesn't show basically the control versus the treatment group and then following them over time. So RCT is considered more reliable, much more reliable than an observational study. Lastly, I would mention here that progesterone is not needed for vaginal estrogen alone. And I believe that's all I have to say here. Next slide. Oh, sorry, back up, stay on this slide. I just want to mention that with the cyclic regimen, you would expect withdrawal bleeding, which can happen while on the progesterone or near the end of the tail end or after the progesterone is stopped. With the daily therapy, the lining is called continuous combined therapy. The endometrial lining would become thin or atrophic, and therefore it would basically, there would be amenorrhea. I'm looking at the time and realizing it's 1:50, so we're going to move a little faster now.
Yeah. Okay.
Next slide.
So just some of the risks, we've already talked about a lot of these risks. I'm going to go through this very briefly. Obviously, venous thromboembolism can occur with estrogen, possibly a higher risk of breast cancer. Again, endometrial hyperplasia or even uterine cancer if unopposed estrogen and they have a uterus. The liver and gallbladder issues. And again, the heart disease and stroke risk is really more concerning if women are started at a later age, which again is not the recommendation. And then you can also have breast tenderness, again, the bleeding, headache, bloating, mood changes. Also for progesterone, again, mood changes. I've heard a lot from women, the bloating and headache. Next slide. Okay, so we're getting back to our case. So she, after all that discussion that you had with her, she did want to start on menopausal hormones. So you started an estradiol patch, and you're going to start the micronized progesterone daily orally. And she comes back and she's so happy with you now because her vasomotor symptoms are much reduced. And so is there a recommended follow-up? Well, again, a lot of times what I will do in practice is I want to see my patients a few weeks after starting. I want to monitor how effective their symptoms are. So if they had 10 or more vasomotor symptoms per day and now they're having 1, you don't need to titrate or change their dose. That dose you gave them initially, even very low dose, working for them. So you don't have to get up to any kind of maximum in this situation, but you do want to monitor and see if they're having benefit, if they're having any side effects. If you're worried about the LFTs or if they were maybe mildly elevated at baseline, or maybe they're on other meds that can raise LFTs as well, I have very low threshold for rechecking those. You obviously want to monitor their blood pressure. And again, all of the other screening is per normal health guidelines, such as lipid, diabetes, and their cancer screening. Next slide. So case 3, a 51-year-old Black woman comes to clinic with vaginal bleeding after initiating the hormone therapy a few months ago. She did have irregular menses prior to that. She at one point had a transvaginal ultrasound that showed that the endometrial stripe was quote unquote unremarkable. Her bleeding is heavy with some clots, but her VMS are improved. So does she need a workup? Next slide. The answer is absolutely. So even though menopausal hormone therapy could cause some vaginal bleeding, she is having postmenopausal bleeding, and it needs to be worked up in her and in all patients. You can certainly do a transvaginal ultrasound to look for other pathologies such as fibroids, hyperplasia, or something else, looking at the ovaries as well. But you still need to get an endometrial biopsy. This is critical. The thickness of the endometrial stripe is not diagnostic one way or the other. And so it actually can be misleading. So you could have either a quote unquote unremarkable endometrial stripe, especially in women of color and those on continuous MHT, and you could miss either hyperplasia, adenomyosis, or even endometrial cancer. And so really, really critical that you do the endometrial biopsy as well. Next slide. Betsy, this is you to take it home.
Okay. And again, I'll be speaking rather quickly now. So 62-year-old has been on hormone since age 52, and she has not had any adverse effects. She's active and exercises. Her mood is good. She's sleeping well. She wonders if she should stop hormone therapy as she worries about breast cancer risk. What are the recommendations? Next slide. So there are really no specific guidelines as to when to stop hormone therapy. There are actually lacking studies on extended duration of therapy. The Women's Health Initiative, recall the slides that I showed you earlier, that there is a increased risk of breast cancer, heart disease, stroke in the older age groups and with increased duration of hormone therapy. And the American College of Physicians recommends tapering hormone therapy at about 4 years for the combined estrogen plus progesterone, and about 7 years if on estrogen alone. ACOG, which stands for American College of Gynecology, says use shared decision-making. So review the comorbidities, general health, any new contraindications, patient preference. And one little point that was made, and one expert speaker, was that bone loss can resume promptly after cessation of hormone therapy. So follow the recommended guidelines for osteoporosis screening and do a baseline or whatnot and follow up if appropriate. Next slide.
I make one comment about both. So the recommendation, again, if you look at the United States Preventive Service Task Force and others, it says start DEXA bone density screening at 65 or earlier. So one thing you could do with these women is actually do a FRAX, F-R-A-X score determination, which you can get online. And if they are at a higher score risk, then consider doing a bone density test and then following that based on that result. Okay, sorry, go on.
And what about breast cancer risk our patient was worried about? So the Women's Health Initiatives, the Women's Health study showed higher risk of breast cancer on hormone replacement. There were 6 more cases per 10,000 patient years in the combined cohort. And we also know that breast cancer risk increases with age regardless of hormone therapy. About 1 in 8 American women are affected. And alcohol intake has increases risk of breast cancer about 7% with 1 drink per day, about 20% for 2 to 3 drinks per day. And I should mention here that it was also, this speaker pointed out that there is increased breast density on mammogram when patients are started on hormone therapy. So patients do need to be made aware of that there may have increased callbacks, there may be more biopsies as a result.